Good afternoon, everyone. I am Trish Armstrong, co-chair of the CLE section of the Florida Bar Family Law section. If you can please mute your audio just so that there's no feedback. Any questions that you have, go ahead and submit them in the group chat. Welcome again to our Zoom program on COVID-19 and reopening. We are very lucky to have Dr. Ryan Day, a frontline physician at MD Anderson Cancer Center in Houston, here with us to offer his medical perspective on COVID-19 and answer questions you have about reopening your practices or reopening in general. Dr. Ryan Day is a surgical oncology fellow and critical care physician at MD Anderson Cancer Center. He holds an undergraduate degree in microbiology and immunology from the University of Florida. He attended Ross University School of Medicine and completed his general surgery residency at Mayo Clinic, Arizona. He is board certified in general surgery and holds a position at the University of California, San Francisco as an abdominal transplant surgery fellow. Dr. Day's current responsibilities include operative and perioperative care of cancer patients, administration of the Surgical Oncology Fellowship, and critical care for surgical and COVID-19 patients at the University of Texas MD Anderson Cancer Center. Welcome, Dr. Day.
Good morning. Thank you for having me. I'd like to start off by thanking Julie, Trish, and Rachel for setting this up. Done a great job with it. And I'll start by talking a little bit about who I am. Thank you so much for the introduction there. You can go to the next slide there. So I currently work as a surgical oncology fellow, which means I primarily do surgery on cancer patients at MD Anderson. And then I do surgery on patients who have cancer, even if I'm not removing their cancer. So patients who have surgical problems that aren't necessarily related to their cancer. In addition to that, I work in critical care, and I've been taking care of COVID-19 patients, in addition to surgery patients who need critical care at MD Anderson. Been part of the COVID planning committees at MD Anderson, doing research and implementing the best practices that we found at MD Anderson. In addition to that, I have experience with prior epidemics in H1N1. I was also working in critical care at Mayo Clinic in Arizona. I actually diagnosed the first case of the H1N1 resurgence in the state of Arizona, and then helped run a 30-bed ICU that was primarily H1N1 patients. I also have some experience working in resource-limited settings. You can see at the bottom, that is me operating in Haiti, where I go once to twice a year to help build capacity for surgery and critical care in Haiti. And then on the right side of the screen, you can see my wife, Sandra, there, who I'll talk a little bit more about later on. But she has lupus, and that kind of enters into some of the discussion and back and forth when we talk about risks and benefits of COVID-19 and our own activities. You can go ahead and go to the next slide, please. So what is COVID-19? I wanted to do some brief background to make sure we're all on the same page and we're talking about the same thing. So the virus originally came from Wuhan, China. The circumstances aren't entirely clear, although it may have had to do with some animal eating practices that they have in that area, specifically related to bats. The virus itself is incredibly tiny, and it's made up of essentially an envelope and then RNA, or ribonucleic acid, on the inside. The envelope allows it to enter our lung cells using this spike protein. Once it does that, the instructions on the inside of it, the RNA, they take over the cells of our lungs, and they turn those cells into basically manufacturing plants for new viruses. So one virus will infect one cell and then take it over. It makes 100,000 new viruses until the cell dies and bursts and releases those new viruses. They infect other cells in your lungs, and then they become droplets as you breathe out and cough and those things. And that's how they become transmissible. We know they're transmissible through droplets, which are things that come out of our mouth. They're like small amounts of spit, basically, that have the virus in them. Aerosols are a particular category that we see less often than droplets. They're mostly seen in healthcare situations when we're doing things like putting breathing tubes in. And that's where the virus is in the air by itself without any surrounding water or that sort of thing. It's a more dangerous situation because the virus is much smaller, and I'll talk about some of the precautions that we take in hospitals for that versus what people do at home. And then recently there has been data that suggests it's also transmissible through feces. So particularly with food preparation, if hand washing isn't used, there is live virus in feces from infected individuals, and it can be transmitted in that way. Next slide, please. So what are the symptoms? Well, one of the most interesting things that's come out recently is that a lot of people are actually asymptomatic with this disease. We started doing testing on the general population for antibodies against the COVID virus, and about 5 times as many people as we know have had it from being tested have had it and either had no symptoms or very minimal symptoms. The other group of people that don't have symptoms are individuals who are so-called pre-symptomatic. There's a 1 to 14-day incubation period from the time you actually contract the virus until you start to experience symptoms. The median day that people experience actual symptoms, if they're going to have them, is 5 days after they contract the virus. For those individuals, those symptoms include fever, but only half of people actually have fever. So some strategies that depend on taking temperatures and those sort of things are going to be missed even by some symptomatic individuals, and they'll miss all asymptomatic individuals. The other common ones are shortness of breath and cough. Most people that have symptomatic COVID-19 will have those. And then there are some less common symptoms, including sore throat. About 10 to 15% of people get a sore throat with COVID-19. Headache, body ache, and exhaustion are a little bit more subjective, so it's harder to say that people necessarily have those or don't, but they're reported about half the time. And then there are some emerging symptoms that I don't have listed here, but the important ones are loss of taste and smell. That's an early symptom that we're seeing even prior to these other symptoms, and it tends to pretend if that happens, that you're actually going to have a less severe course of COVID-19. And while we originally thought that children were far less affected from a symptomatic perspective, from the large outbreak in New York City, we're actually seeing a group of children with something called Kawasaki's disease, which is an autoimmune manifestation of COVID-19. There's been about 150 children in New York City that have come down with that now as a result of COVID-19 infection. Now, these are all short-term symptoms, and it's very possible that COVID-19 could have long-term symptoms or manifestations that we don't know about yet. At the end of the day, this virus has only existed for 4 to 5 months at this point. So we don't know what's going to happen in years down the road. Some other examples to think about are like the chickenpox virus. Well, you get that as a child, right? And then, or a lot of people in this room did before the vaccine existed. But then as you become older, 65, 70, it remanifests itself as the shingles infection. They're the same virus, and it's been latent in the body that entire time. There are other viruses like the monovirus, which can actually lead to some cancers later on in life if it becomes reactivated. There is a possibility that there could be long-term sequelae of COVID infection. We just don't have long-term follow-up yet because we're not in the long term. Go to the next slide. So how bad are the symptoms for people who get them? So the rates of hospitalization increase with age. Young individuals, 5 to 17-year-olds, only require hospitalization 0.1% of the time, 1 in 1,000. But if you're greater than 85, 17.2% of people end up requiring hospitalization, and that number is probably a little bit low at this point. The average hospitalization for people that don't require critical care is longer than a week, which is actually a very long hospitalization for an acute illness. Most other types of pneumonia or influenza tend to be more on the 3 to 4 day end. Individuals who require critical care for COVID have really bad outcomes. 50% of people who require being put on a ventilator end up dying from COVID-19. Frequently, they have other critical care issues, including the need for dialysis and other supports, including for their heart. You can see in the pictures on the right the precautions that we have to use when we put breathing tubes in people. It's one of those aerosol generating procedures that are particularly dangerous. We've been using boxes around people's heads, special respirators, and ventilators. And then if someone ends up on a ventilator for COVID, they end up staying in the ICU on that ventilator for about 2 to 3 weeks, which again is a really long stay in the ICU and ends up being very resource intense for each individual that ends up in the ICU. The fatality rates, they're different depending on what sort of metric you want to use. If you look at a case fatality rate, which is taking the number of diagnoses in the United States and dividing it by the number of deaths, our current case fatality rate is 6.7%, which is really, really high. But now that we know that there have been asymptomatic individuals or minimally symptomatic individuals in the community that comprise about 4 to 5 times as many as the number of people we've tested, that infection fatality rate we're thinking is somewhere in the 0.5 to 1% range. That's still really high for an acute respiratory illness like this, certainly higher than influenza or similar other respiratory infections. Fatality rates do increase with age and comorbidity status. So certainly people that are over 85 are at the highest risk, but really anyone over 65 is where you start to see things really start to take off. And then individuals who have respiratory comorbidities like COPD don't do well with this disease due to their increased oxygen demands. And then people with diabetes and other diseases like autoimmune diseases also don't do well because of their intrinsic immune dysfunction. Next slide, please. So what are the treatments that we have available to us for COVID-19 right now? There's been a lot of news about remdesivir, which recently had a positive study. It was originally developed for Ebola. It shortens the length of the hospital stay, but it doesn't have any effect on mortality. And in fact, the paper that they wrote that showed it shortened the length of hospital stay, there's been a major flaw in the statistical analysis that's come to light in the last day or so. And it turns out that remdesivir may actually not even work to shorten the hospital stay. It'll require further study to figure that out. Hydroxychloroquine, at this point, I'm very safe saying there are no benefits to hydroxychloroquine. People do worse, actually. They die at higher rates in the majority of studies that have been published. Several have had to be shut down due to safety issues, and they've had increased rates of complications. It's also depletion of a national resource. Individuals like my wife who has lupus use it for that disease, and there's been trouble getting it for them. At this point, I would not prescribe hydroxychloroquine to any patient that was in the ICU, that was an outpatient, or for preventive reasons. And then there are other treatments, tocilizumab, convalescent plasma. There's a lot of investigational treatments that are still out there that we just don't have the evidence. We haven't run the trials on them yet to know. Some people are using them, some people are not, and we do have trials open. But the most encouraging news has always been with a vaccine, which is the major way that we can we fight most viruses that we experience in the modern age. The issue with the vaccine is it's going to take a while not only to identify the correct vaccine. There's several promising ones that I'm cautiously optimistic about, particularly Moderna and AstraZeneca both have encouraging vaccine candidates at this point. But the issue is going to be production. Once they make it through those multi-phased trials, getting them into actual production at a level where you can immunize 300 and some odd million people in the United States, really the earliest that's even feasible with a long shot is next year. There was actually some good news otherwise the other day in that now the neutralizing antibodies have been identified from people's serum. And we may be able to develop a treatment, a monoclonal antibody that can be administered based on that. But again, that's 2021 at the earliest. So we're kind of stuck living with this virus and not having great treatments for it in the meantime. Next slide, please. So one thing we have to do is test for the virus. And there's a couple different types of testing. I know some people sent in questions about The types of testing, is it feasible to use them in an office setting? What does that look like? Well, at this point, there's really two tests that you can use to see if someone's actively infected with COVID-19. The first is a PCR test, which is the one you see being administered there. It's not really practical to administer to yourself or without a medical professional because it's not just a swab inside the nose. It actually feels like it's tickling your brain as you get tested, and it's quite invasive in that way. The other test is an antigen test, which works on saliva. That's still a little bit more investigational at this point. And one of the issues with these tests is even some of these tests that have been FDA approved at this point, like the Abbott test, still have high rates of false negatives and false positives. There are other ones that are developed by different labs that do better, but there's a wide variety between these tests. And then there's also antibody testing. The idea behind antibody testing is that you've been infected at some point in the past. You've beaten the disease, whether you were asymptomatic or symptomatic, and now you've developed neutralizing antibodies that will protect you in the future from COVID-19. For a while, we had questions about, did people develop antibodies? Did it confer immunity to this disease? We've seen pretty good evidence now that people who have been infected do not get reinfected with COVID-19. They develop immunity to it. The question at this point is, how long does that immunity last? So for other coronaviruses, the immunity only typically lasts about 2 to 3 years. So we may see that natural antibodies are not the way to go necessarily in this disease, and a vaccine may be needed kind of on a yearly basis, similar to the flu. The other issue with antibody testing right now is we've done a couple of prevalence studies. So specifically in Florida, California, areas that have had a moderate amount of COVID-19, we've tested swaths of the population, and about 3 to 5% of the population has antibodies against COVID-19 at this point. Some people have suggested that, well, we could test people for antibodies, and anyone who has antibodies could then go back to work. The problem is that's not really a valid strategy when only 3% of the population has antibodies, because there's inaccuracy in the antibody test. It's a very good test, but it's only accurate about 95% of the time. So if you take 1,000 people and 3% of them are going to be true positives, that's 30 people that are positive and have true antibodies against COVID-19. On the rest of the 1,000, since you have 5% inaccuracy, 50 of them are also going to test positive who don't actually have antibodies. So at this point, you would have more false positives than true positives if you tested the population, and you would be submitting people who didn't have antibodies to risk. So that's why that's not a great strategy at this point until a much larger swath of the population has developed antibodies. Next slide. So how contagious is the coronavirus? It's a very contagious disease, and what we use to signify how contagious the disease is a statistic called R0. And that's how many people one person with the disease will infect with the disease if all things are left to themselves. So without social distancing, without any other measures, masks, etc., the coronavirus R0 is between 2.5 and 3.5. Average that down to 3, but you can see how quickly this builds. One person infects 3, that becomes 9, that becomes 27, and you get this exponential building for any time you have an R0 above 1. So with a lot of what's happened with social distancing, with shutting down the economy and other things, we've gotten this R0 in most places to either 0.9 or 1.0, which means each person's infecting largely one other person or less. If you can keep R0 below 1, then your numbers decline over time. If you keep it at 1, then they stay the same. But as we start to lift restrictions and people go back to work and they have more contacts, that R0 is going to go up again. The strategy to beat that while continuing to reopen society is test, trace, and isolate. The idea is that you have to have enough contact tracers, and our current data says we need about 300,000 contact tracers in the United States in order to trace the number of people that are going to have this. And that's a specialized job that requires training. Prior to this outbreak, the United States had about 3,000 to 5,000 contact tracers working for state and federal government. So you need a large number of people doing that. And then the idea is they trace individuals who come back as positive, they trace all of their contacts, and then you test the asymptomatic individuals. So once you test the asymptomatic individuals, you can isolate them and hopefully keep the R naught low. Next slide, please. So the epidemiology in the United States at this point has been greater than 1.5 million confirmed COVID-19 cases. Serologies suggest a 4 to 5% infection rate in endemic areas. There are other areas, like some portions of the Midwest, that have had lower rates to this point, but it's suffice to say those are going to be going up everywhere. And at this point, there are 95,000 confirmed COVID-19 deaths. And you can see in the map kind of where the hotspots in the United States are by county at this point. Next slide, please. So the next couple of slides are to show a little bit about how people are charting this data and how different charts can present the same information and give you different impressions. So it's important to really be critical of these things and have sources that you trust to interpret these. So this is a common chart that people have seen on the news everywhere else, and this is what's called the logarithmic chart. So if you look at the y-axis of the chart, it goes up by a factor of 10 each way, and you see the United States is right at that million mark. Well, the next line on that chart is 10 million afterwards, but the space between 1 million and 10 million is the same as between 100 and 1,000 cases. So as you start to get to really advanced numbers, this is going to naturally tail off as it gets rid of the population. But it's great for charting the exponential growth in the original phase. Next slide. So this is a chart that's showing the exact same thing as the last chart. It's just not on that logarithmic scale. If you look at the left side, the y-axis, this goes up by a normal amount at each increment. So you can see that this looks like a vastly different situation. The other graph had leveled off, whereas this one still appears to be going up at largely the same rate. So it just depends on how you want to visualize that data. Both of these graphs show the same thing, and you could make two very different points to people by showing these two different graphs. Next slide. So the next thing we can break it down is this is actually the same data. This shows just the number of positives each day, and a way to smooth that out is that rolling 7-day average. Because what you see is there's a spike every 7 days where it goes down and down and down every 7 days. Well, that's the weekend, and reporting of cases tends to be much lower on the weekend. So using something like a rolling average gives you a much more accurate prediction than every weekend going, oh, our cases are coming down. It's safe to open things, it's safe to do things. Next slide, please. And here you can see just even subtle changes in the way the data is recorded and reported can show you very different things. So this is the same thing. This is the death count as it's tracked by the CDC and by the COVID tracking project. The red lines are the CDC's tracking of deaths, and they appear to be coming down, whereas the COVID tracking project's deaths are stable or moving up, actually. And the reason is the CDC reports the deaths on the day that the death happened. So they frequently get a report of a death, and they have to go back and they modify it several days ago to increase the count there. Whereas the COVID tracking project reports all deaths on the day that they are reported. So you can see those two different ways of doing that give you a very different view of even the same piece of data. So it's important to look at all these things critically when you see them on the news, that sort of thing. There's always kind of a point of view being presented, and you want to really get all the data before you make up your mind. Next question, or slide. Oh, well, that's sad. But in addition to the ones that you just saw, there are intentionally misleading graphs as well. This was a picture that was put out by the Georgia Department of Public Health, and it had the dates out of order to make it look like COVID cases were decreasing when they weren't. Next slide, please. Okay, seems some of the pictures didn't go through here, but the public health goals of what we've been trying to do with COVID-19, you can see in the chart at the top right. and that's the so-called flattening of the curve. The point is to not overwhelm the healthcare system, because mortality is going to go up when the healthcare system is overwhelmed. We don't have enough ventilators for people. We don't have enough protective equipment for hospital staff workers. And people are going to die from other diseases. For instance, if you come in with a car crash and all the ventilators are taken by individuals who have COVID, then you end up dying of that car crash, even though that would have been preventable under other circumstances. So the point of social distancing and masks and some of the things I'm going to talk about was to flatten out that curve so that we stayed under hospital capacity. Several communities, New York City, exceeded their hospital capacity, required very valiant efforts in order to get things up to snuff there, but they were able to get there just right at the teetering of their new hospital capacity. But the problem with flattening the curve, or not really a problem, but a consequence of it, is that it prolongs the infection period. It drags it out over time as opposed to being all up front. So you should have lower aggregate mortality if you stay below the hospital capacity line, but it is going to be a longer, more smoldering course over time. One of the benefits of it being longer over time is that you also have the ability to develop treatments. So some of those antibodies, vaccines, those things that I talked about, you have less people that are infected before you get to that point. So that's largely the public health goal that we see. Now, what about masks? And I'm sorry, a couple of these pictures didn't come through either, but the one at the top middle is supposed to be cloth masks. The cloth masks are largely what the public's been advised to wear. And the point of these masks is not to protect the individual who's wearing them. It's to protect each other. So droplets are about 5 to 100 micrometers in size. The point of wearing a mask is to stop droplets from being projected from your mouth onto other individuals. So a little cheeky graphic in the top right hand there about pants and the analogous situation of masks. So really, when out in public, wearing a mask, it shouldn't be giving you a license to do things like be closer to other individuals or take high-risk behaviors. What it should be, what the purpose of it is to protect other people that are around you if you happen to be an asymptomatic carrier. As we go to reopen workplaces, that sort of thing, this is going to be an important measure against asymptomatic spread. The picture on the bottom left was supposed to be an N95 mask, and then next to that you can see a P100 mask and a PAPR, which are things we largely use in the hospital. These are things that we use to protect ourselves as healthcare workers from individuals who are infected. They have a much higher filtration rate than, say, a cloth mask, and they can catch the COVID-19 molecules that are about 1 to 3 micrometers in size. What they don't do, though, and I've seen a lot of kind of false reports about surgical masks and N95 masks and even cloth masks, making you rebreathe your own carbon dioxide. That is a straight myth. It is not true. There is no mask in existence which causes you to rebreathe your own carbon dioxide. We've actually done studies on physicians who've worn these masks for 12 hours during a day. We draw their blood and we actually look at the levels of oxygen and CO2 in their blood, and it's the same after wearing them as it is beforehand. Now, some people get headaches with masks, and I've heard that from a lot of different people. It tends to be from the straps around the masks actually being too tight, as opposed to any sort of impaired gas exchange or anything along those lines. The only individuals who really have difficulties with masks are individuals who have underlying anxiety issues, individuals with autism that can't have masks touching their face and have issues with the physical sensation of that. And then people with baseline severe respiratory diseases, people with COPD, people with severe cystic fibrosis. Sometimes those people have difficulty generating the pressure they need to breathe in a mask. And I would argue those individuals shouldn't be out in public anyways at this point, as an infection would almost certainly kill those individuals. And then finally, in the bottom right-hand corner there, you can see a face shield, something we use in the hospital when we're doing aerosol generating procedures. but it's actually also an option for people that do have anxiety or problems wearing a mask. You can actually wear a transparent face shield like that in public, and it would be both protective for you and other individuals as well. So it's just an option that a lot of people haven't necessarily thought of as a face covering. Next slide. So as opposed to the public health goals, we have individual goals, and largely that's not to get ourselves sick, it's to protect our family. And then it's continue to make a living and protect our employees as we go to reopen things and try to do that in as safe a way as possible. So what does that look like? So the first and most important thing is hand washing. I've seen a lot of people, for instance, in the grocery store and other settings that are currently wearing gloves. I think that's a really bad idea to be using gloves. When we use gloves in a healthcare setting, what we do is we wash our hands, we put on the gloves, we do one thing that has an exposure, then we discard the gloves, and then we wash our hands again. So they're only to protect you from that one exposure. In public, when people wear gloves, what they end up doing is touching one thing, then touching something else, then touching something else. They're cross-contaminating everything that they're touching. You would be much better off doing frequent hand washing as opposed to using gloves in that situation. The next thing we can do is limit in-person meetings and the number of people that need to be in a room together, both the number of people, the duration of people, and the distance between the people. So indoors, air conditioning systems, central air systems, like most places in Florida have been implicated in some spread of the virus. In addition to that, there was recently a meeting in California. It was a board meeting of 13 board members for a company. They had a 9.5-hour in-person meeting, and one of the individuals was pre-symptomatic with COVID-19. After that 9.5-hour meeting, 11 of the 13 individuals in the room were infected. I'm sorry, I'm hearing that there's some issues with volume from the chat there. Okay, some people are indicating no. Okay, well, I'm almost at the end, so I'll keep going here and then we'll try and troubleshoot that. So the next thing, in addition to limiting the in-person meetings and as far as number and duration, is asking people who are coming in whether they've had contacts with people who are positive for COVID-19. Have they had a cough at home? Have they had a fever? Have they had anything that would be symptomatic? Have they traveled to areas outside the country or to areas like New York that have had large amounts of COVID-19? So every day that I go into work right now, there's a big sign and I have to attest to each point that I haven't been tested for COVID-19 and I'm waiting on a result, that I haven't traveled outside a 7-county area, that I haven't had any of these contacts. So it's a good idea to have this for both your own employees and then people that are coming into your practices. Next is temperature monitoring. At MD Anderson, we use these laser guns you can see on the top right. They give you a contactless temperature for each individual coming in. It's a good idea to monitor temperature in some way on people that you're going to be coming in contact with, particularly for long periods of time. The issue with temperature monitoring is, again, even symptomatic people, only half of people develop a fever, and they don't have fever all the time, it's intermittent. So what a lot of people have done is had people take their temperature at home prior to come in, and employees monitor temperature once to twice a day is a way of looking at that. The issue with having people monitor their own temperature is even at MD Anderson, we surveyed all of the healthcare workers at MD Anderson. We asked how many people had a thermometer at home they could use to do this. Only 40% of healthcare employees have a thermometer at home, and I would venture that that's probably less in the general population. So that's why using something like a contactless temperature monitoring system can be a good thing. Next thing is disinfecting high-touch surfaces. So there's a list of 11 high-touch surfaces there. It includes things like keyboards, mouses, steering wheels, refrigerators. Those are all important things to disinfect throughout the day. We've got some data now that particularly touch is maybe a little bit less of the way that this virus is transmitted. So that's certainly good news, but continuing to disinfect those surfaces between people and touches is a great thing to do, in addition to hand washing in order to prevent spread. The next thing is you have to give people the leeway, if they're sick, to stay at home. Anyone who's symptomatic in any way should be at home and not coming into the office or another environment where they can infect other people. This took a big change in kind of the paradigm in healthcare. Doctors frequently come to work sick, and we feel like we have to power through things and just deal with it. And I know that a lot of attorneys can have a similar view of just work through it and you'll get to the other side. And that can't be the case with COVID. It's so infective, and the consequences are so high for it that it just, it can no longer be that same kind of paradigm. If you're feeling unwell, you have to stay home, and really, to protect the office, you have to have other employees who are feeling sick have a way not to come into the office. Any work that can be done remotely, I would still suggest should be done remotely. This is just for those situations where you have to have something in person. And again, you want to limit the amount of time that people are in contact with each other. You want to continue to use things like face masks. So for instance, say you had someone coming in who needed counseling about something, and then they needed to sign a document. You could still do the counseling remotely and then have them come in and just sign the document. It's going to require kind of hybrid approaches like that in order to help prevent people from getting infected. And then the final thing to consider is in your public-facing parts of offices or other areas, you can use shields. A lot of grocery stores have gone to these plastic shields. They're actually relatively cheap to get and install in order to protect your employees that are public-facing that don't need prolonged interactions. So I think that's about all I had as far as prepared talking points. So I hope that was helpful, and I'm glad to help with any questions at this point.
That was very helpful. Thank you. And we do have some questions. One of them was about slide 8. I'm going to start from the top, about the R0 number. Richard West wanted to know if that was the current R0 number. I know that that was the initial thought, but I'm reading studies not from the White House that say it's closer to 1.5.
So there's a lot of different studies on the R0, and a lot of the methodologies are flawed regardless, because it's hard to test this in a truly laboratory type situation. It's borderline unethical. Based on social distancing, we've seen R0s of 0.9 and 1.0 in the real world. I do think the true R0 is more on the 2.5 to 3 side, but regardless, anytime you're over 1, you're going to see growth and spread of the disease.
Okay. And a question about the masks. Can the N95 paper mask be effectively washed with soap?
So we actually do not use soap to reuse N95 masks. We reuse N95 masks. There's a couple of different ways to do it. One is with using heat, like in an oven type situation, but you can't have the mask actually touching any surface within the oven. It has to be hanging by something else, so that can present practical concerns. There's a way of sterilizing them using radiation, but typically when you get these masks wet, they actually kind of stop to function. So using soap and that sort of thing is not a great way to do it. Another way is UVC light. I know there was a question that was submitted last night about, does UVC light kill this virus? It does, but the issue with UVC light is it's also dangerous. UVC light is not something that's normally in our atmosphere. It gets filtered out by the ozone. We have UVA and UVB that hits our skin. UVC is a higher energy light. It is used in hospitals for disinfecting rooms of troublesome infections, including COVID-19. But the issue is it's also dangerous to you. It's much higher energy than the sunlight we get right now, so it causes things like skin cancers, incredibly high rate. So if you're going to use something like that, you have to be really careful about the exposure you're submitting yourself or others to.
Mhm. And a question came in, how much safer are we in groups outside versus inside?
So a lot of it depends on the dynamics of those groups, who's in those groups, what other activities those individuals have had. So when you're with somebody else, you're essentially trusting that every contact that they've had is also not someone who was potentially symptomatic, anything along those lines. As to indoor versus outdoor, the jury is out a little bit. I do think outdoor is safer. Central air conditioning systems have been shown to recirculate the virus and place them into different locations. There was one paper from a restaurant in China that posited the only way certain spread could have happened is with their air conditioning system. So at the end of the day, it is probably somewhat safer outside versus inside. But just remember those respiratory droplets, those sorts of things, they can linger in the air for up to 15 minutes. So really any interaction with other people is always going to have that risk-benefit analysis associated with it right now.
Okay. And wearing a mask, does your mouth and nose need to be covered by the mask or just your mouth?
Yes, your mouth and nose need to be covered by the mask for it to be effective. Just covering your mouth is actually as ineffective as not wearing a mask.
One question came in, our law office has about 12 people working in it. We are able to be 6 feet apart. Should I require everyone to still have masks on during the workday? We do not have public or clients in the office at this time. And then a follow-up to that is what masks are the best to use?
So in that sort of situation, I think using cloth masks or surgical masks that kind of loop around the ears are the two best options. I would have individuals continue to use masks. For instance, at MD Anderson and any associated institution, even those that don't provide direct healthcare, we still wear masks indoors at all times, except when eating. So that is kind of the one exception, because there's no real practical way to eat with a mask on, and people still need to be able to do that. But yes, in an indoor situation with 12 people in an office, I would emphasize that they should wear masks, and individuals who can do their function from home or remotely should still be allowed to do that as much as possible. Each person that you decrease in the office decreases your potential exposure quite a bit.
Okay. A question about someone having a pre-existing condition, but being under 50, will wearing a homemade mask and hand washing really protect me?
So the homemade masks, they don't provide protection to the individual who's wearing them. So other people wearing masks will help protect you. Hand washing will help protect you. But it's still, even if you're meticulous about those things, there's still a chance that you can get infected with this virus, particularly if you're in public and around other people. There's just kind of no way to avoid that potential risk with how infective this virus is. So again, you just have to consider the risks and benefits of different activities as you put those back into your life. I can tell you that I haven't had a haircut in quite a while now. I'm not eating out at restaurants despite them being open in the area because the risks of those activities are just too high to me personally, having patients that I'm going to see in a hospital and having a wife with an autoimmune disorder at home. So you have to kind of take your own inventory of those things and how much risk is worth it to you.
Mm-hmm. Do you have any suggestions for cleaning AC systems when you have to be indoors with others?
So for cleaning AC systems, the best ones that are similarly used in airplanes now are kind of HEPA filter ones. They can filter out about 99% of the virus if you have a HEPA filter on your central air. That's probably the best way to go at that. Using standalone air purifiers that are separate from central air probably don't do a whole lot in that regard.
Okay. Should we limit the number of client meetings and how many people should attend them?
Yes, you should absolutely limit client meetings to the bare minimum of whatever is necessary, the bare minimum of the people that need to be in that meeting, and limit the length of the meeting. Uh, and then also limiting the activities of the meeting. I don't think any of you are having people say, for instance, sing at the meeting, but that would be a high risk activity. And one thing that worries me with seeing, say, churches reopen is there singing going to be going on? Similar to the group that had the 13 people in the boardroom, there was a choir group of actually 90 individuals who met, kept 6 feet apart, and practiced their choir songs. There was one pre-symptomatic individual in that group, and after a 4-hour rehearsal, 60 of the 90 individuals ended up ultimately testing positive for COVID. So there are both high-risk activities, exposures, length of time. You need to limit all those things to kind of the bare minimum of what's necessary to get the task done.
Right. And how long do you think, with all the reopenings now, there's a lot of pressure to sort of get back into things. How long do you foresee us having to really limit contact like this?
Yeah, so there's really only a couple ways that this ends, so to speak, and that social distancing can go back to normal. And that's one, a vaccine is developed and is distributed widely, and we develop herd immunity from everyone being vaccinated or a large proportion of the population being vaccinated. 2, it goes on long enough that almost everyone has had the disease at that point, and then they have recovered and developed antibodies. We don't know how long those antibodies will last. So that could be a temporary situation, but that is another way that things could get back to normal. And the third way that you don't hear talked about as much is if an effective treatment is developed. So a lab recently found 14 neutralizing antibodies, and they're working on producing those into a medication that can be given. If that were to be successful and that prevented people from dying or having severe disease from this, then I think as a population, we could go back to the point where we didn't have to do these things. But even with the social distancing in place and the masks that are being used right now and other social strategies, it's not clear that even those are going to be enough to prevent us from needing to shut things down again in the future. Now, I don't know if there will be political willpower to do that, but it is possible that we could get close to overwhelming hospital systems in other areas and need to shut down again. So it's hard to say at this point. We just don't have all the information, and we're still at the very beginning of this, but I don't see it going away anytime soon.
Mm-hmm. So one question came in about requiring clients to wear masks in our offices. Is that something that we should require them to do?
I certainly would. To come into MD Anderson right now as a patient or anything else, you have to wear a mask. I wouldn't want to be exposed to individuals who aren't wearing a mask. I can tell you the scariest part of my week is when I go to the grocery store and I see people without masks on. It really does help limit that droplet spread. And remember, it's protecting you. It's not protecting them. And I think you have to be cognizant. If you're going to have a lot of people coming through an office, then you're increasing your exposure quite a bit. You have to do things to mitigate that exposure. And one of those things is requiring clients to wear masks.
And how do we protect ourselves in our offices and common areas such as break rooms, kitchens, copy machines? And what about offices that share public bathrooms with other offices in the building?
Yeah, so the main thing with those things is going to be avoid touching your face, hand washing, and then frequent disinfection of those surfaces. So it's a little bit difficult to get things like Lysol wipes right now. So if an office is going to reopen, I would definitely suggest trying to source those things and then placing them frequently with easy access throughout your office. Also place hand sanitizer if you have it available throughout your office. And then take steps to decrease the number of touches in different areas. Like if you have doors that are in your office that require people to pass through very frequently, instead of having everyone touch that door, consider propping it open, that sort of thing.
So should high-risk individuals work from home until there's a vaccine if they can continue to do that?
I would absolutely suggest that. A lot of different companies, including MD Anderson, has taken about 40% of the workforce at MD Anderson is working from home, and now MD Anderson is working to make that a permanent situation for those employees. I believe Facebook just announced that they are also transitioning to a more permanent work from home model. If you can work from home and you can effectively do your job, I don't see any reason that you need to expose yourself to other people and increase your risk of contracting the virus.
In gyms, do increased respiration rates make the spread more likely?
So anytime you're breathing more heavily or you're doing things like singing and you're projecting, droplets are going to go further away from your face in just a straight distance sort of situation. We've used kind of the 6 feet as a safe distance. There's actually studies that show droplets can spread further than that. The furthest study I've seen is about 13 feet. But yes, vigorous breathing, deep breathing, exhaling forcefully will cause things to spread further. A gym is not a situation that I'm going to be in the near future. You know, my wife and I are doing our exercise at home in the apartment and taking walks, being far away from other people, that sort of thing. I think outdoor exercise activities or not being in a public gym situation is ideal at this point.
Okay. I've heard that ACE2 receptors are mostly common in lungs and heart tissue. Are there any medicines you know of that affect ACE2 receptors, helpful or dangerous?
Yeah, so that's a great question, actually. There were some thoughts early on in this disease. There's a antihypertensive medication. It's called lisinopril or losartan are the two, and they're ACE inhibitors or ARB blockading medications. There was some thought that maybe if we use those medications in people, it would prevent them from getting infected. That largely has not panned out as a therapeutic option. We have not seen better results from people doing that. And this is in line with our experience. Oh, sorry. I was going to say this is in line with our experience with other viruses. There are not that many viruses that you can think of that there's a treatment for. There's a couple that have been very recent things, like hepatitis C getting treatment in the last decade or so. But if you think about, you know, the common cold, influenza, all these other things, we don't have neutralizing treatments for the vast majority of viruses.
2 more questions. Would you send your kids to school when they do open?
So that's a really difficult question, and that's one thing that makes me glad that I don't personally have children, because I don't have to make that decision. But there's going to be a couple different factors that go into that. The first is, do your children possess any predisposing health conditions? So if I had a child with cystic fibrosis or something like that, then that would be a hard stop no for me. The danger with schools is less to the children themselves, we think. There is some risk associated with, say, the Kawasaki's disease that we've seen in New York, but even that's happening in very low numbers. The main risk of sending children to school is that they act as vectors. So if if a child's parents are infected at home, and then the child gets infected, but they're asymptomatic, as the majority of children are, then they spread it around at school, then all the other children take it home to their parents. It's more that vector phenomenon that I worry about with schools than necessarily the risk to individual children from going back to school.
Okay, we're gonna start wrapping it up here. Is it safe to use grocery delivery services like Instacart? What about one-on-one personal trainers?
So any interaction where you're using one individual in a controlled situation is going to be better than being in public and using a lot. So like I would use a personal trainer, a single personal trainer, versus being in a public gym. I think that's a better situation. But then you also have to think about that personal trainer, how many people are they personal training and coming into contact with as well? So that can be kind of a difficult situation, but I think it is preferable being like, say, in a big public gym. My wife actually has a personal trainer, and she has been doing Zoom workouts with her personal trainer that have worked quite well. So I think that's another option you can potentially look at there. And then, sorry, I forget the first part of that question. Oh, Instacart for groceries. So based on what I see at the grocery stores in Houston right now, I see a lot of people that are close together, a lot of people not wearing masks, that sort of thing. Again, it is kind of the most stressful part of my week is when I'm in there because it's this uncontrolled situation as opposed to when I'm at work and everyone abides by safety distances and wears masks and takes these preventative measures and washes their hands all the time. Instacart, I think, is a better situation, grocery delivery, especially now that we're getting evidence that the virus doesn't transmit as well off surfaces. So things like the bags are probably less infective than we originally thought. So I do think that's a preferable option, that curbside pickup, to being in the store for a prolonged period of time, exposed to a wide number of people.
And last question, should a high-risk individual postpone in-home physical therapy?
So that's another one of those risks and benefits situation. A lot of things like someone who's had a stroke and they're getting physical therapy afterwards, a lot of those gains that you get back from physical therapy, it's not possible if you delay the physical therapy. You start to develop permanent losses. So the question becomes, do you want to take your risk up front, or do you risk permanent disability in those situations? And you've got to weigh those things against each other. It's certainly a situation I talk to your doctors about and I talk to your family about in order to prioritize what your goals are. For some individuals, that physical therapy, not getting it, could be completely debilitating for them in the long term, and they'll take the risk of getting the virus. For other individuals, it's something that it can be put off and there's no long-term sequelae of that, and they can limit their exposure in the meantime. The only problem with putting off something like that may be a medical necessity is I can't tell you when it's going to be safe to do in the future or when this is going to resolve. Under the best case scenarios, we're looking at, the middle of next year sometime. So I don't think you can put things off indefinitely. And that's part of the kind of existential crisis that this country is facing right now, is we can't put things off forever, but we have to do things to mitigate risk as well.
Well, thank you so much, Dr. Day. Really, it's been great, really informative. I hope everyone has enjoyed the opportunity to go one-on-one with such a qualified doctor. So we really appreciate your time. Thank you very much. And thank you everyone for attending. Have a
Very well.
safe
Thank you for having me.
weekend.